So, good evening, everyone. And today is the second of the series of talks which we have for NESIR. Some housekeeping items first. Once we are done with this talk, you'll be getting an email, and all the people who are present in this conference should go to the EEDS site and try to log in and register there, so that they can get the CME down the road. And with that, and we'll at the end of the year we'll have another questionnaire. Please ensure that you fill it back to us so that we can improve as we do every year. With this, I'd like to invite Dr. Constantinos Sofocleous. Belovedly, we call him Costi.
Very good.
That's good for both of us in terms of saying. He's a professor of radiology at Weill Cornell Medical College in New York and Sloan Kettering, and he's famous for his work in colorectal cancer. And we decided to have a series of lectures on intervention oncology because that has become such a huge part of IR. So this year we decided to dedicate two sessions. One which starts from the past, brings us to the present, and the second, how we are doing in terms of research, and which will be the second series in the coming months. So with this short introduction, and Costi, in addition to that, he is the counselor for international global outreach for SIR, and we interact a lot on that front. So I'll welcome Dr. Sofocleous to take the control and carry on with the talk, please. Thanks, Costi.
Thank you, Iqbal. Thanks for the invite. It's very exciting to meet you virtually in these tough times. I'm looking forward for a glass of wine at some point in proximity. This talk is a little strange because you will see an historic review of interventional radiology and oncology. Because they're blended, really, it's very hard to separate them. But let's see where we stand and where are we going with our specialties here. Here are all my disclosures, some of which may come relevant to some of the slides that I will show, as I have received research support from some companies that deal with Y90 and ablation devices as well as software. Now, I don't know about you, but I've been in this situation in nice parties in the middle of nowhere. Nobody knows who I am, and then suddenly, the nightmare kicks in. I'm sure you have all been in this scenario, and the question is, what do you do for a living? And then you say, of course, I'm a physician, but then you're trying to explain what exactly are we doing. And I think there was, for many years, the interventional radiology identity crisis. Are we really clinicians? Are we really more people who read images? What really are we? And it was very hard to explain to people, including my own parents, that actually I'm closer to a surgeon that is using imaging, or maybe an interventional cardiologist. That's something that they know more often. They have faced something like that on a friend or a relative. And I would say things that, I'm a physician doing procedures using imaging, similarly to what they do in your heart with a balloon or a stent, having to explain to them that even interventional cardiology, of course, started in a radiology laboratory. So then we move from interventional radiology to interventional oncology. So what is interventional oncology? So I looked it up, and based on Wikipedia and etymology, interventional oncology, I'm going to abbreviate it as IO, is a subspecialty field of IR that deals with the diagnosis and treatment of cancer, cancer-related problems, and it uses targeted, minimally invasive procedures that are performed using image guidance. And I think it's fair to say that interventional oncology actually corrected this historic struggle of IR identity. And it corrected it in a way that at least the patients and referral physicians can understand that we're dealing with cancer, and they relate to that name easier. So interventional oncology collects and builds on the IR techniques that apply to cancer and unite them under a single disease state. And of course, with this definition, with the establishment of the subspecialty, there was a lot of things we had to do. And the first thing we had to do is what the entire world of IR had to do, is acceptance by others And I don't know if you guys remember this, but 15, 20 years ago, no IR participation was there in any disease management team because we had no data. And therefore, for interventional oncology, it was no different. We were the new kid on the block, and it took a lot of work and a lot of internal and external politics to really sit at the table. So let's see some milestones. And I looked that up in Wikipedia, and anything is blue is actually interventional oncology, whereas the yellow involves the entire interventional radiology spectrum. So it's interesting, in 1960, there was actually radioisotopes Y90 investigated for cancer treatments. 1970, we started doing embolization and having agents that we could administer in liver tumors. In the 80s, we had cryoablation with the initial known problems, and then we had laser interstitial thermal therapy. And it's not until 1990 that we have radiofrequency ablation for soft tissue tumors, for bone, breast, kidney, and other parts of the body. And you can see here HIFU appearing in 97 and chemoperfusion to 2012. And your own Melvin Klaus from Harvard is one of the first people who actually described percutaneous fine needle aspiration biopsy in 1977. And then you can see hepatic arterial infusion, 1978, and more intraarterial therapies for tumors, 1979, 1983, and again, Melvin Klaus, hepatocellular carcinoma, chemoembolization with oil, 1993, and more of that in 93, and I will go on and on. And even today, if you think about it, the most common thing we do is actually biopsy and vascular access, only that the biopsy we do today in 2020 versus the biopsy of 1977 when it was first described is very different, especially when it comes to a cancer center. Most of the biopsies we do now, at least in my institution, in our practice, is to evaluate the mutational environment of the tumor rather than make a morphologic diagnosis that is usually done already in the community. It is very interesting that in the 90s, if you think about it, it's only 30 years ago, one generation, we really had locoregional therapy only for one organ and mostly for one disease. It was chemoembolization and ablation and mostly hepatocellular carcinoma. The first description of electrocautery by Tito Livraghi was in RSNA abstract presentation in 1994, done with ultrasound guidance, no anesthesia, of course, maybe some local there, and you can see the sterility environment back then. And of course, the new millennium, the 2000, came with great growth for interventional radiology and in particular for interventional oncology that helped build evidence for the practice of interventional oncology. First reports evaluating ethanol injection to surgery that demonstrated very similar outcomes, especially when it comes to survival, as you can see here for early HCC. Subsequent reports compare radiofrequency ablation, and many of them showed better outcomes than ethanol injection, and many of them in randomized control settings. This continued for many years with multiple randomized trials of radiofrequency ablation versus surgery, versus ethanol injection, and so forth. And of course, I'm sure that you all know the pivotal trials that brought in chemoembolization as the standard of care for unresectable HCC because, again, in the early 2000s, from different institutions, it was shown that oil chemoembolization with doxorubicin with prolonged survival when compared to best supportive care. This created the very first level 1 evidence in interventional oncology for HCC, both for intraarterial therapy and ablation. and this resulted in the inclusion of interventional oncology therapies as standard of care, both for small HCC under 2 cm, where ablation is now recommended ahead of surgery, but also in intermediate stage HCC, where chemoembolization is again standard of care today. So it took about 20 years of strong work to have both intraarterial therapy and ablation as standard of care in the guidelines for HCC, and this happened sometime around 2015 for ablation, earlier for chemoembolization. So we can say that at least we are sitting on the table, at least for HCC, for a good decade now in interventional oncology, if not longer. The story was a little bit tougher for colon cancer, for example. For colon cancer, the story started by offering interventional therapies as a salvage therapy, whether it will be ablation for patients who are not resectable or who recur after resection, and the same for intraarterial therapies, where again we would only treat patients with chemorefractory disease and those that could not be resected. It's not surprising that very early results, this is from my own institution, the results of radiofrequency ablation compared to surgery were terrible. But of course, if you think about it, why wouldn't they be? All of these patients were not resectable candidates. 50% of them had prior hepatectomy, and a lot of them could not undergo any resection. More importantly, there was no margin analysis to stratify patients by those that could be treated with margins versus those who could not. Margins are extremely important in surgery, and we knew this for years. This is a 2007 publication essentially showing that there was no patient that made it to 10 years after diagnosis of colorectal cancer if at resection didn't have negative margins. And this was again repeated, same information, 2018, same group of surgeons reported that again, one of the factors that determine cure is actually the ability to resect the liver metastasis with clear margins. Now, looking at the surgical literature, we were actually able, eventually, 2012 now, 5 years later, after I showed you the paper that said that ablation is much worse than limited resection in the liver, we were able to start thinking about margins, and actually we went back and stratified all of our ablations by the ability to have a margin around the tumor or not with anatomic landmarks. Very low budget method, no 3D software at the time. The striking finding of this work was the fact that although we thought that we had a margin that was at least 5 millimeters, look at the numbers. Out of 94 tumors, 71 had a margin under 5 millimeters, and 30 had no margin, with a 74% local tumor progression failure within 2 years, concordant with the area of the minimal margin, 100%. This started giving some answers of why we had so much more recurrences with ablation compared to resection. At that time, here at Memorial, we mandated that if you were to do a liver ablation, you had to do a contrast-enhanced CT after the ablation in order to be able to dictate that you ablated the tumor sufficiently and with margins. We didn't ask people to actually measure the margin at the time, but you can see that just telling them that they have to show the ablation zone, our local progression-free survival was much improved. You can see here being over 75% at 20 months, staying over 67%, over 2/3 at 30 months out of the ablation, and you can see how bad it was before. This is comparisons before and after 2009 when we implemented this change. And of course, subsequently, we and others evaluated the results of thermal ablation based on margins, and it was clear that if you can actually have margins over 10 millimeter, local recurrences will be under 5, and if you can have at least a 5 millimeter margin to 10, then recurrences will be in the realm of 15 to 26%. As a matter of fact, we and others subsequently demonstrated that if we can achieve the 10 millimeter margins, we can show that there is no recurrence whatsoever. So if you have 10 millimeter margins, the patients are here regardless of whether you treated them with RF or microwave for that matter. Now, another information came that was actually probably the most important information for initially non-resectable disease, colorectal liver metastasis, and this is the CLOCK trial by Ruers et al. It's a surgeon that performs ablation in the Netherlands, in Amsterdam, and he demonstrated that the addition of RF ablation to standard of care, oxaliplatin-based chemotherapy, actually had a significant prolongation in patient overall survival. As we can see here, 35.9% at 8 years, whereas under 9% for people treated with chemotherapy alone. Again, this is level 1 evidence, small series, but very, very strong signal, and this allow us to put ablation in the NCCN guidelines, as a matter of fact, earlier than 2018, indicating that ablation can be used alone or in combination with surgery as long as all visible disease can be eradicated. A subsequent meta-analysis in 2019 actually reviewed, as you can see here, 328 papers out of 3,530, and 48 of those were included in this analysis, where it showed that actually microwave had very, very similar results to partial hepatectomy, both in terms of oncologic outcomes as well as morbidity for that matter. And they made the point that is extremely important when you're discussing this today, that as of 2019, the only ethically acceptable trial or question is whether and when thermal ablation can be offered instead of surgery. Is no longer ethical or acceptable not to offer ablation in a patient and just treat them with chemotherapy if they have a tumor that actually can be ablated with margins. And of course, these tumors are small, and the RAF indication is up to 3 tumors, none of which is over 3 centimeters. This study here is a prospective randomized trial that is open and accruing right now in the Netherlands by Martin Meijering, and he recently, last week, actually, a couple of weeks ago, presented in CIRSE his preliminary results showing no inferiority of thermal ablation when compared to hepatectomy. I hope that we will see the final publication soon. Now, with all this data, of course, there was a huge technologic development. I showed you this picture of Tito Livraghi back in 1994 performing thermal ablation in a liver tumor using only an ultrasound machine and barely having any other help. And you can see a room that we have today where we combine ultrasound and CT fluoroscopy and even PET guidance in my institution, and I know as well in Harvard. And in addition to that, we can also have cone beam CT and CT arteriography, and we have microwave and irreversible electroporation and cryoablation and whatever else we can think of. Very, very different environment that allows us to treat much, much more challenging tumors and locations. I want to talk a little bit about the evolution in my place through the years, and I want to say that in 2009, as a matter of fact, we opened our Center of Image Guided Intervention, where the majority of these procedures are now performed in anesthesia platform. and we have any imaging equipment needed from PET to MRI to C-arms and cone beam CT, as well as hybrid rooms combining CT and C-arm together, allow us to have navigation, to have 3D software and depiction of tumors and vessels, and certainly much higher ability to assess our treatment zones. Here is an example of a 3D software that we often use now intraoperatively, and I'm sure that you have seen different softwares that do this, and they can depict with much better accuracy the margin around a target tumor, and hopefully they can be used intraoperatively. Similarly, through the years, we have learned that when we're treating, especially colorectal cancer, it's extremely important to apply our technique to the genetic information we have for tumors. Both us and MD Anderson colleagues have seen that a 10 millimeter margin is great for wild type tumors, but for maybe the mutant, this may not be sufficient. 17% recurrence in the MD Anderson cohort, and for us, when evaluating suboptimal margin, you can see that wild type tumor can be controlled with a 5 millimeter margin or less, whereas the mutant, if you don't achieve higher margins, they will definitely recur with a very, very high rate, 17 times high likelihood of recurrence if you're mutant with inappropriate margins. We have also developed techniques that allow us to combine metabolic imaging with anatomic imaging, blend the portal venous phase with the SUV signal, and allow us to accurately biopsy the tumor center as well as the margin after ablation. And we do know that combining this information, we can have much better outcomes for those tumors that are ablated with over 5 millimeter margins and their biopsy proven complete necrosis at the end of ablation. We now combine all of these modalities in the angio suite with 3D navigation, real-time, as well as real-time biopsy, where we can interrogate those cells not only for morphology, but also with viability stains that they can tell us right away whether they are alive or dead. And this is actually an open clinical trial under an R01 that we're enrolling right now, and allow us to retreat if there is residual disease at the end of the first ablation. This sums a little bit the ablation work, and I'm going to move into the intraarterial therapies, again in the colorectal space. As you know, intraarterial therapies have been developed over the last 20 years or so. And of course, the key question that comes to mind when we discuss this with many of our oncologists is, why do you even bother treating colorectal mets that are hypovascular? Well, the truth is that when you put a catheter in the artery, very often these mets are actually still supplied by the artery much more than the portal vein, despite the fact that in the portal venous phase they may look hypovascular. Now, as you all know, there was a great development with the application of yttrium-90 impregnated microspheres that we use for colorectal liver mets, and that achieves much higher radiation to tumors than any other image-guided radiotherapy could achieve. As a matter of fact, we exceed what would cause liver failure, as you all know, just because we are able to target the capillaries and deposit the spheres directly into the tumors. Within the years, there was a lot of trials that allowed the investigation of this device for colorectal liver mets. I want to remind you all that the FDA approval was on this paper in 2001, where actually at the time there was very little chemotherapeutic agents for the disease, and the resin microsphere was given through a pump in the GDA with fluoxetine when there was no irinotecan, no oxaliplatin, and it got FDA approval, which then led to a series of events, one of which probably many of you have seen is a small randomized study that actually showed, one of the first studies that showed extended time to liver progression, extended time to progression, and better overall survival in the study arm, despite the fact that there was a crossover. And of course, this didn't reach statistically significant, but they did allow crossover from people who progress in the control arm into the study arm. This was a very strong signal for liver disease control. Subsequent large retrospective reviews from the United States with resin as well as with glass demonstrated pretty much the same data, showing that survival for responders can be roughly around 12 months, regardless of what you are using. And more recently, we actually managed to do a nomogram where we showed that if you assign points based on factors that we know are impacting outcomes, such as tumor size, presence of extrahepatic disease, CA, albumin, tumor differentiation, ALT, and so forth, you can actually see that even in the chemorefractory stage, there is a tremendous variability in tumor biology. Therefore, you can see here that 1 year survival can be 90% for patients who have low risk factors, under 25 in this nomogram, versus 10% for those that accumulate many of these risk factors, over 80, based again in this nomogram that was described. Of course, you are all familiar with the very, very well-known and considered negative Serflox trial that administered resin in 3 different trials, altogether over 1,100 patients. Half of them got standard of care chemotherapy, oxaliplatin based. The other half got Y90 in addition to Volfox. And you can see that despite the fact that the trial did not prolong overall survival, there was a significant prolongation of liver control by 8 months. And you can see here no difference in overall and progression-free survival, despite the fact that the liver was significantly better controlled by the resin. And we can talk about it after this presentation if you all want to. From a subgroup of the same trial, it was shown actually that right-sided disease has a survival benefit when they receive Y90, and you can see here a prolongation of overall survival to 22 over 17 months with a 36% protection against death if you are actually in the treatment arm. More recently, I'm sure you all noticed, the EPOCH trial was a randomized trial where glass yttrium-90 microsphere was given with combination of second-line chemotherapy. What is the second-line chemotherapy? It didn't matter. It was essentially any oxaliplatin or irinotecan-based chemotherapy, as long as the patient had previously received one or the other. This study has mild prolongation of the median PFS to 8 versus 7.2 months, and hepatic PFS to 9.1 over 7.2 months, which may seem very modest. However, the way I would like you to think about that is that when it comes to PFS, you have a 31% protection against progression, and when it comes to the liver, any progression, it's 41 protection against progression in the liver. And that's the way we have to present it, especially to oncologists. This is exactly what they do with their drug trials. So when it comes to colorectal cancer, we have been able to be again in the NCCN guidelines, and we have been at least in several points. And in terms of treatment, again, ablation, that it can be considered alone or in combination with resection, arterial directed therapies, that is an option in highly selected patients with chemotherapy resistant refractory disease, predominantly hepatic metastasis. Of course, portal vein embolization, standard, and for those that you may hear that IMRT should go ahead of ablation, well, this is really not supported by the guidelines, so at least you can use that if you feel that you can ablate the tumors with thermal ablation. The same story is repeated in pretty much every single cancer that we have. And it's true to say that back in 2015, a lot of these panels for neuroendocrine, for kidney, for non-small cell lung cancer did not have an interventional radiologist in the panel, and they didn't have specific recommendations. I was very happy to see that actually for neuroendocrine tumors, as of 2021, there is a whole page, Principles of Liver-Directed Therapy for Neuroendocrine Tumors, where embolization and all of the modalities, TAE, TACE, yttrium-90, and ablative therapies are mentioned. Should really be saying Principles of Interventional Oncology. I think we should actually work on that to strengthen actually the presence of interventional oncology as the fourth pillar of cancer care in a lot of the disease that actually we provide meaningful therapy that manages the disease either by prolonging overall survival or allowing the patients to live with management of the disease without having to get prolonged cytotoxic chemotherapy. Despite of that, there are still challenges in interventional oncology, and they are often. We are still asked to provide healthcare value every day. We have still issues with reimbursement. There are still a lot of political issues, and of course, we need to standardize our practice, improve our education, and so forth. I will start with a little story that tells what happens locally. As we all know, all politics are local, and here at Memorial, we now are a full clinical specialty, but when we started back in 2007 to have an IR clinic, I saw 8 patients back then, one of which was a patient that had HCC and was embolized with an excellent result of his embolization, despite the fact that I got this complaint letter from a very VIP referral who was telling me that although I did a wonderful job with the embolization, the person was extremely upset because I saw the patient in clinic before and after the procedure, and I was asked to never do that again. Thank God we didn't hear that, and you can see the increase in numbers through the years. 8 patients in 2007, 367 patients in 2017, and still growing in a very nice environment of an IR dedicated space. And along those lines, during this time from 2007 to 2018, you can see that our IR faculty went from 6 to 23, and we now have faculty assigned to disease management teams, as you can see here, from HCC, lung, colorectal, GU, palliation, and so forth. So there is a tremendous growth that has happened, not only in the literature, but also locally. The same happened with our societies. I don't know if any of you is old enough to remember Tuesday night RSNA ablation workshop. That was the beginning of an association between people who were treating tumors with ablation. Some of you can recognize some of them here. This is Gigi Salviati. This is Fred Lee, for example. And since then, we went to 2005, where it was the first innovations in cancer therapies meeting. Again, that's already 16 years ago. Then we had ECIO, the first one in 2008. And then the WCIO for the first time, 2006. And eventually we had the birth of SIO in February of 2017, which joined the ranks of other interventional societies, much bigger and much more wide spectrum than the focus of SIO in the interventional oncology space. Now, I like to make this analogy of interventional oncology and radiation oncology because they both came from radiology with a difference of 50 years. Radiation therapy left radiology in 1967. Interventional oncology became officially a subspecialty in 2017, a little bit after interventional radiology actually became an accredited specialty separate from diagnostic radiology, standing on its own. What is very important, and I like to have all of us think, is the success of radiation oncology in proving their value in the healthcare system. They created the Radiation Therapy Oncology Group within the NIH NCI. Now it's actually part of the NRG. And as of the last time I looked, that was a couple of years ago, they had, this is actually as of 2019, they had 500 protocols, they had enrolled 100,000 patients, and they had over 1,000 papers. And that's something that really we need to replicate if we want to succeed in interventional radiology and interventional oncology. Here is an example of we could actually learn from them. We all think of local therapy as a vaccine against cancer with immunotherapy. Radiation therapy thinks the same, and we have very similar problems, and that may be a reason why we don't see the abscopal effects that are actually case reports, because they are so rare. We all know that we had the same issue with ablation and cryoablation. We all know that the reason is the PDL1 and PD1 axis that tampers the local therapy induced anti-tumor immune response. And we have to start thinking, how can we join forces with all this environment, all these treatments in interventional oncology, radiation oncology, surgical oncology, immuno-oncology? I think the cancer landscape in 2050 is going to be very, very different. We will need to start thinking individualized, tailored cancer care for each and every patient. It's extremely important to collaborate and find synergy. I think 30 years from now, we will have medical oncology administering chemotherapy or targeted therapy. We're going to have immune oncology that will be developing immunotherapies, vaccines against cancer. They're going to have synergy with local therapies, hopefully will be relevant. We're also going to have gene oncology with genetics, gene manipulation, gene delivery, gene therapies. So what is going to happen with all of these things that I talk about for the last 40 minutes? Is there going to be any invasive therapy? I'm not sure, but if it's going to be, it better not be surgery. I think it's going to be image-guided intervention, and it's going to be together, surgery, rad-onc, interventional oncology, whatever you want to name it. It's going to be minimally invasive, and it's going to be ideally guided with minimal blood, with minimal if any cut. And I actually look forward to that, because that's the time that I probably will need some therapy. I'd rather have it without any needle or cuts. And with these thoughts, I would like to thank you for the attention, and I'm really, really thankful for the invitation and looking forward to questions and discussion. Thank you very much.
Amazing. Great talk. Honestly, really like it.
Thank you.
Good. Anybody has a question? I'm sure you intrigued a lot of people, so there must be a lot.
Well, I try to create a little questions here rather than
Yeah,
have a conclusion, to be honest.
exactly. You open up the future.
Exactly.
Anyone want to
Hi,
ask?
Dr. Sofocleous.
Yes.
Yeah, go ahead.
Hi, my name is Deepa. I'm a research fellow. I'm very interested in kind of the overlap between IR and urology. I know if you may be familiar at Mount Sinai, they have a field that's being developed called interventional urology.
Yes.
And I'm just curious what your kind of work and overlap with them is. Thank you.
Well, I don't know much of what they're doing there, but certainly, if you notice, that's how I close the talk, because I think there are going to be a lot of image-guided intervention in every single field, whether it's urology or others. And I don't know how we're going to transition this. I have a feeling that image-guided therapy will blend into every single field of medicine, and eventually it's going to be bloodless. I actually hope that it eventually will be totally bloodless. I don't know if I'm answering you specifically, because I don't know the specific program, but happy to talk
Yeah,
about it more.
perfectly.
So, anybody else has a question?
I have a question statement.
Yes.
Is that okay?
Sure.
Yeah.
I want to thank you for your address. I think sometimes we get so caught up in doing what we do, we don't appreciate the history of it. And as we were discussing before you joined us, NESIR is really one of the two organizations that gave birth to the national organization, along with the Philly Angio Club. One of the things that we're noticing in this era, I've been in things a long time, we had this era where things were being conceived but couldn't be rendered. Then we had the era where we were able to devise these platforms and start doing things, especially around making diagnoses. And that's what I did a lot of my training with catheter-based angiography. Then we moved into the 90s where really robust treatments started to come out. We were really curing disease. I'd like to think we're in the threshold of a new era. I'm not quite sure what it is, but what I hope at least part of it is one is which we actively seek to combat disparities in patient care and to have better outcomes for all of our patients who are in need. We're aware that there are significant disparities in the treatment of people of various backgrounds when it comes to coronary artery disease, peripheral vascular disease, uterine artery embolization. Our patients with end-stage renal disease and hepatic disease also face significant disparities. It's my hope that as interventional oncology really continues to expand, that disparities are something that they pay close attention to. And that when we're doing research projects, that there is specific verbiage that seeks to create patient groups that are by their very nature diverse, because our communities are diverse. Was that okay to say?
Yeah. As a matter of fact, it's it's a requirement in the NIH grant writing that you have to pay attention to that. If you ever go to the federal government and ask money for a research, they want you to describe that as something you have thought about. Same goes with sex. So disparities, background, and sex orientation is something you have to start thinking about it.
Thanks for the point raised, Herschel. It's a very strong point because you join two different fields like diversity and IR, and I think diversity has to be a part of the discussion down the road because it's long due. And I think one of our resident probably has a follow-up question to this same discussion.
Yeah. Oh, hi, Dr. Sofocleous. It's Li Wei. We met a few weeks ago, actually.
Hi.
So actually, a follow-up question to Dr. McGinnis's question regarding disparities. So, during your talk, I was thinking that a lot of this is certainly no doubt very technology driven, certainly with modality like PET-CT guidance, able to visualize ablation margins and, to much more clear than, than some alternatives. But then leads me to think, in terms of disparities and access to healthcare, let's say someone has the access to a center like Memorial Sloan Kettering, they get, the top-notch therapies, have great outcomes. But, what do you think about patients who are, maybe not so fortunate? They have their community hospital, maybe, IR is not so developed there. Sort of like, well, what do you think we can do to kind of help everyone?
Yeah, I think that's a very good question, and I think you are actually bringing up a very, very important point. But I think one way to address that is a minimum standardization of practice, and one way to see that is that let's take a simple one. Like if you are doing ablation and you cannot even evaluate the margin at the end, then maybe you shouldn't be doing it. Now, I'm not asking you to do it with a PET guidance, but there is a minimum way you can do it pretty much anywhere, which is, use a contrast-enhanced CT before and after, and have your techs make a 3D depiction of the tumor and the ablation zone, so at least you have an idea that what you are planning to do was achieved. So as a matter of fact, I hope that we will have soon a trial that is addressing that, where it mandates that any patient that gets ablation has to depict the margin in order to be enrolled. And it's not going to be everywhere, but at least it's a pilot to standardize practice between different interventional radiologies. And I think that's part of what we need to do that goes even in the advanced centers. So many times you will hear that we all say, oh, I did a chemoembolization at Penn, and I did a chemoembolization in Paris, and I did a chemoembolization in Dublin, and one in, I don't know, New York, and none of the 4 treatments is the same because every practitioner does whatever they want. So the standardization of our practice, it's a limitation that we need to address, and the sooner we do it, the better it is. Otherwise, we're not seen by others as organized or serious enough, if you wish. So that's certainly one of the points we have to address.
Yeah,
thank you.
Yeah, great explanation, Costi. And I can add up to this a little bit because, we can take a leaf from radiology because this was a similar case about CAT scan or MR read in 4 different cities, 4 different radiologies. All of them have like certain like way of reading things. However, they are trying to standardize the report. The same thing SIR is working, I know, on standardizing the report, that these are the requirements that you should fulfill before you can finalize the report, and probably a procedure in that order. For example, in your case, you are saying that you should have a negative margin, or you have to mention like how much margin was achieved, because as you know, it's a direct correlate of margin versus survival. Yeah, so great question, great explanation. Anybody else has a question before we move on to the next phase?
Not a question, but a comment.
Sanjeeva, yeah.
Costi, I think you mentioned very nicely interventional oncology as the 4th pillar of oncology therapies. And if you talk to immuno-oncologists, they will think that immuno-oncology is the 4th pillar. Having said that, to sustain as a separate specialty as interventional oncology, we need to develop a groundwork in terms of providing a specialty practice, specialty fellowships after interventional radiology that includes some training in radiation oncology, medical oncology, surgical oncology. So probably a 2-year program, a 3-year program to make it much more sustainable in the long run. You had to talk the same language, you had to develop a similar design of protocols, able to sit on the table and under discussion about new therapies that are coming into picture. So as a society, both IR and IO societies, what do you think the future would be in terms of training opportunities for people to develop interventional oncology skill set?
So I'm not sure what exactly will happen, but that's exactly why I said in the one before last slide that actually in the future, it's going to be intervention in one bucket in a way, if you wish. So I don't know how we're going to reach that and how it's going to look. But as you said, I can see interventional oncology as part of other invasive treatments such as radiation oncology or surgical oncology, if it exists in the future as we know it today. That I don't know. But I agree with you that immuno-oncology and genetics actually will become big parts of treating disease, and in particular treating cancer. So I think interventional oncology is such a small part of the whole picture, and it's going to be part of the intervention in the future. So I can see what you said becoming a real need, where you get cross-training of image-guided intervention with surgical intervention and radiation intervention as one cross-pollinating field. I'm not sure how we're going to get there, but the technology may force us to do that. Once you start having rooms, like we already have a glimpse of that, right? We have MRI in neurosurgical rooms, and soon we're going to have, image equipment in any surgical room. So what will be the difference of interventional oncology than, let's say, surgical oncology? It's going to be very little.
Yeah, great explanation. Yeah, that's one of the fears which we saw. I remember my day when my last day of fellowship was the first day of London building at MGH, which is where they had these high profile rooms, hybrid rooms, where the MRs come into the OR. So yes, that's the fear, but we have to embrace it and we have to fight it with data. And that brings me to the question which Sanjeeva said. If we have to have that fellowship kind of thing, there should be a strong emphasis on research, because this is what I feel like, personally speaking, whenever we do go to conference, we don't have as strong data as the oncologists when they come up about a disease process or any of the specific process we are talking about. So in addition to all those trainings, we should have like a big chunk of research, just like the oncologists do. They have like 3 months a year of research dedicated to it. So we should fight this with data, at least. Sure.
Sure.
Good. Anybody else has a question? Great discussion. Like, love it. Like, very different than usual. I like it. So with this, we should move on to the next phase of the presentation. I would call upon, we have 3 presenters, one from, let's see who's next. Tommy, are you there?
Yes, I am here.
Yeah, so I'll call upon Tommy on. I was going by alphabetical order. That's why I call you first. Nothing personal. So Tommy, you can take the screen share and then get going.
Sounds good. I think Constantinos, if you stop sharing, I'll be able to share my screen.
Oh yeah, sure.
Can everyone see this PowerPoint?
Yeah.
Yes, we can.
Perfect. So I prepared a case to share at this conference today. My name is Tommy. I'm one of the IRDR residents at Mass General Hospital. I'm in my 5th year of residency right now. So I'm presenting a biliary case, a bit of history on this patient. It's a 78-year-old female. She had a laparoscopic cholecystectomy performed at an outside hospital in July of last year, and it was complicated by a bile duct injury. She was evaluated here by our surgeons, and they performed a Roux-en-Y hepatococcygeostomy in order to repair her defect in the bile duct. Her postoperative course was complicated by a stricture at the hepatococcygeostomy, and I've shown a representative image here from an MRCP that she had performed, where you can see an abrupt cutoff at the level of the hepatococcygeostomy, where there's some degree of biliary ductal dilatation in both lobes of the liver. In the interim between January and when she presented to us in IR, she did have endoscopic dilation of her hepatococcygeostomy. However, the effects of those dilations were not durable. So she presented to us in September with elevated LFTs. Her T-bili was 2.6, AST and ALT were elevated as well, and she was presenting with a bit of dark urine. So IR was consulted for percutaneous biliary intervention, given the Roux-en-Y anatomy, which makes it difficult for our endoscopists to get to the HJ, and also the fact that her prior endoscopic dilations weren't very effective. So our initial plan when we get patients like this was simply to angioplasty the hepatococcygeostomy stricture after obtaining biliary access. And we often leave an internal-external biliary drain and bring these patients back for serial dilations every few weeks, often for 3 dilations in order to achieve a durable effect. So we started this case by accessing the left-sided biliary ducts, and we were able to gain access to a peripheral biliary radical. Here on the left-sided screen, we were able to advance a wire centrally through the hepatococcygeostomy, and initial contrast injection through a sheath demonstrated actually a patent hepatococcyg, but there was some degree of narrowing there. So we angioplastied, I believe this is a 6mm balloon that we used. And our intent at this point was to do a final cholangiogram and leave an internal external biliary stent. But on our cholangiogram after the angioplasty, we noticed this filling defect within the left-sided duct near the HJ, which we assumed to represent a biliary stone. So at this point, we decided to perform multiple sweeps with a Fogarty balloon with the intent of sweeping it through the HJ into the duodenum. So this is a little video clip of one of our sweeps. And we performed several, and we also re-angioplastied the HJ when we weren't initially successful. And eventually, after sweeping the stone several times into the duodenum, we weren't able to see it on the left side anymore. So we placed our internal external biliary drain. I believe this is an 8 French. And we thought this was our final image, so we did a final contrast injection. However, we then noticed that the stone seemed to have migrated over to the right-sided biliary duct. So all we had done was, dislodged it. It's a mobile stone, obviously, and it probably was causing intermittent obstruction, which led to her presenting to us. So at this point, we removed our drain, replaced the sheath, and initially attempted to sweep it with a Fogarty balloon placed up into the right-sided ducts and sweep it down into the HJ, but we found this difficult just based on our access from the left side. So we decided to use an ensnare device to try and capture the stone. It was not an easy process, took us many attempts, but eventually we were able to snare the stone. And I know this is a video where we're capturing a radiolucent stone, so you can't tell that we were able to grab it, but from a tactile sensation standpoint, once we captured the stone, you could feel a degree of resistance with the basket or the ensnare device wrapped around the stone, and then a sudden give way once we assumed we broke up the stone. So after this point, we did another cholangiogram, and we noticed that there were now multiple smaller filling defects in some of the peripheral biliary radicals on the right side, and then on the left, which are not shown. We attempted to Fogarty sweep, all of these right-sided biliary ducts as well. But given at this point, the length of the procedure and also the fact that we were in a fresh access and not a mature tract, we decided to place an 8 French internal external biliary drain and bring her back for a subsequent visit. But we felt good that we had performed the angioplasty and macerated this larger stone into smaller pieces with, the prospect of either passing these stones in the interim or bringing her back and performing further intervention 2 weeks later. So in brief, we saw her 2 more times in the month following. We brought her back 2 weeks later for repeat cholangiogram. We saw a couple of the small stones still remaining, and we were able to sweep them through the hepatocogeg. We still left an internal external biliary drain at that time and brought her back 2 weeks later one more time. And a repeat cholangiogram, which I'm showing here, demonstrated resolution of all filling defects, presumably with no remaining stones within the bile ducts. So at this time, we removed the drainage catheter, and she's been asymptomatic and with normal OLTs since. So overall, this is a presentation of a successful transhepatic removal of a intermittently obstructing biliary stone in a patient with Roux-en-Y anatomy and hepatocogeg stricture. So I'll talk briefly about transhepatic biliary stone intervention from the interventional radiology perspective. Biliary stones are the most common cause of non-malignant biliary obstruction. We don't see these cases all too often, as you guys know, due to the fact that first-line therapy is ERCP in patients with normal anatomy. It's relatively straightforward or a relatively routine case for endoscopists to perform ERCP, perform sphincterotomy, and sweep stones out of the CBD or from within the liver. The presence of biliary stones can lead to obstructive jaundice, cholangitis, and pancreatitis, and these are often intervened upon even in asymptomatic patients. So from an IR intervention standpoint, we will see these patients when it's difficult for the endoscopists to do their intervention. So for example, in patients with post-surgical anatomy, like this patient who had a Roux-en-Y hepatocogeg, in patients with a large duodenal diverticulum, which may make it difficult to cannulate the ampulla, or if a patient has impacted stones within the intrahepatic ducts that are difficult to access from endoscopy. So I'll talk briefly about a paper that talked about an experience among 261 patients for transhepatic biliary stone intervention. And although endoscopists are the first-line therapy for most of these patients, IRs actually have a very high success rate at percutaneous removal of biliary stones as well. Among the 261 patients studied in this paper, they had a success rate of 95.7%. And they used a similar technique. They angioplastied the ampulla prior to sweeping stones into the duodenum. And these are representative images where you can see a filling defect here in the CVD. They balloon angioplasty the ampulla, and then I believe this is the Fogarty balloon here that they're using to sweep over wire into the duodenum with resolution of the filling defects on the final image. Notably, the success rate for biliary stone intervention for IRs seemed to be very high in the setting of CBD stones, presumably because it's a straight line to push them out from the CBD into the duodenum. A much lower rate, 61.5%, seen in their study in patients with hepatic stones, similar to the one we saw in this study. I briefly wanted to talk about spyglass or intraductal cholangioscopy, which is a relatively newer toolkit in the interventional radiology armamentarium for treatment of biliary stones. It's been used in different centers for the last few years, according to papers. We just got this capability at MGH recently, so I haven't had the chance to have a hands-on experience with it, but we did discuss using this for the patient that I presented if she had persistent stones on our last visit, but fortunately she did not. In brief, this is a Boston Scientific device that allows for direct visualization of the biliary ducts, essentially a scope that has ports that allow for intervention, including biopsy, stone lithotripsy, etc. It measures about 3.3 millimeters in diameter, so it can be used through a 12-French sheath. And I'll briefly present images from a case report that I came across, which used the spyglass in a similar setting to that I presented, where a patient had a hepaticojejunostomy and an obstructing stone in the right biliary ducts. Here in the upper left-hand image, there's an obstructing stone labeled in yellow within the right hepatic duct, and here we see it on a cholangiogram. In this upper right-hand image here, you can see the spyglass scope being inserted through the 12-French sheath. I thought this was pretty amazing because we don't often see images like this, in interventional radiology. Most of the stuff we do is black and white, but here's a direct visualization of the impacted biliary stone that they were able to use laser lithotripsy for and sweep through the hepaticojejunostomy successfully. So here are my references, and I just wanted to open it up and see if anyone in the crowd had any experience with the spyglass at their institution, and also take any questions that people might have.
Nicely done. Nicely done. So anybody has a question? I have a comment. So in my previous institution, we used to see a lot of hepatico-JEJs and a lot of post-transplant patients. So what happened in those situations, if there are multiple stones, we would access the jejunal loop and go from below, and we will dilate the ampulla, the anastomosis, and then it's easier to pull stone down rather than push stone in. So that's something, if you have multiple stone, you might be able to do. However, with the new spyglass, things are changing quite a bit because you can break the stone much smaller with lithotripsy and everything else. If there are no questions, I will invite our next presenter, Raya Al-Halwani. And Raya, are you there?
Yes, hi.
Yeah. Okay, go ahead. You can take the control. Tommy, you can release the control, please.
Right. Are you guys able to see my screen clearly?
Yes, we can.
Okay, so I'm Raya Al-Halwani. I'm from Beth Israel Deaconess. I'm currently rotating at Boston Children's, and so I took this opportunity to actually present a pediatric case. Pediatric trauma cases we don't come across them very often, and so I found this case to be very interesting, and I wanted to share it with you guys. This is a case that is courtesy of Dr. Chaudhry and Dr. Ahuja. So basically, this is an 8-year-old previously healthy girl who presented to the ED after a fall. She was at the birthday party and fell from a 4-feet high zip line onto a 2x4 and hit her flank. She was initially evaluated at an outside hospital where she was hypotensive, requiring transfusion. Her hematocrit there was around the 32s. A CT of the abdomen and pelvis non-contrast was done, along with other imaging studies, of course, of her head and neck. She was transferred to BCH, and she received 6 units of packed RBCs, 5 units of FFP, 12 units of platelets, 12 units of cryo total, basically at the outside hospital at BCH and en route. So here is her CT from the outside hospital. Basically, as you can see here, this was not subtle. So we can see that there is a very large right perinephric hematoma. The right kidney is significantly enlarged when compared to the left side. And of course, there is hemiperitoneum that extends into the pelvis. Okay. So when she came into Boston Children's, our interventional radiology team was consulted. And so we took the patient for an angiogram. This is an aortogram, basically showing just the general vasculature of the abdomen. You can see that her peripheral vessels are clamped down as would be expected, and then basically her shattered kidney with this somewhat, if you can tell, an active extravasation. Of course, we went on to select the right renal artery. And here you can obviously see the active extravasation from a branch, basically a right interpolar branch. We went on to try to super select this interpolar branch. We started actually selecting from the top towards the bottom, and in the superior pole, you can see that there was normal flush of the kidney. The vasculature started actually to clamp down here, and there wasn't any active bleeding from this axis. We retracted our access and tried to redo our run from basically the right renal artery. And as you can see here, that the vessel actually has clamped down, and it wasn't bleeding anymore. There were multiple actually attempts to recatheterize this right interpolar renal vessel. However, like repeated angiograms showed that it was basically clamped down, bleeding ceased following multiple attempts to cannulate this small branch, probably related to the manipulation, and so she had vascular spasm and decrease of flow. So the patient went on to be admitted to the ICU for hemorrhagic shock, secondary to her severe right kidney laceration. She was now volume overloaded. That's basically, as you can see from the prior, from my prior slide, she received 6 units of packed RBCs and 5 units of FFP, 12 of cryo, and 12 of platelets. She was in acute respiratory failure from that, and she started having hypoxia and hypercarbia, and evolving ARDS. So, of course, we had a cross-sectional imaging of her abdomen, and this was actually the next day, just because of her continued hypovolemic shock. So you can see here that, of course, she has a severe laceration of her right kidney. This was graded a grade 4/5. However, you could not really observe a specific active extravasation from here. So I'm just going to show the venous phase as well, just for completion purposes. There we go. So you can see that there are branches going so that are supplying the whatever is left of the normal renal parenchyma, but not really active extract. So 2 days later, she developed hypotension. I'm sorry, this is going a little crazy. She had diminished urinary output. They ended up fluid resuscitating her, and they adjusted her sedation. Her IV fluids were up to 1.5, her maintenance. She did not have any frank hematuria. Her abdominal girth has increased and her creatinine continued to uptrend. However, her H&H remained stable. She did have spike fevers, which was attributed to her basically ischemia and hemoperitoneume. On day 4, she underwent cystoscopy with right retrograde pyelogram, and they ended up placing right urethral stent. Day 5, she remained intubated in the MICU with a Foley and a right urethral stent. She was continuing to be hemodynamically stable. She started having blood tinged urine on day 6 of her admission. On day 7, she was extubated. When she woke up, she was complaining of right flank and abdominal pain, fevers, and she remained on Lasix. On day 8, she was actually out of bed, moving. Day 9, she started having some tachycardia. Her blood pressure was stable. And during this time, her hemoglobin continued to be actually stable and her creatinine normalized. On day 16, she developed blood tinged urine again, which prompted imaging. This is a sagittal image of her right kidney. And I don't know if you can tell the small amount of normal right parenchyma maybe here. But the rest of it was like basically a large hematoma / urinoma in the middle there. And so, of course, she went for a CT, and on here, we appreciated that she had this pseudoaneurysm, or possibly pseudoaneurysm in the interpolar region, basically right here. And so, I believe I have also imaging of the venous phase. And you can see, of course, that there is a collection in the right retroperitoneum. Yeah, right here is where the pseudoaneurysm. So we ended up bringing her again to the interventional radiology suite. And here you can see on angiography, we basically did the first run. We didn't see any active extravasation, and we really couldn't really tell if, like, we couldn't appreciate the pseudoaneurysm clearly on our angiography. So we super selected the superior pole and trying to see if we can appreciate it better. It was questionable at this point, and so we ended up doing a CT, or a cone beam CT on the table. And here you can appreciate very clearly the pseudoaneurysm. And so right there. So we reformatted the images, and we picked an angle, and you can see here that we could really see the pseudoaneurysm clearly on this angle. And so we ended up measuring the caliber of the pseudoaneurysm in order for us to decide on the choice of coils. We coiled the pseudoaneurysm, and of course, the afferent and efferent side of it. And this was actually the run post-coiling without any active extravasation. And so she ended up doing really well. We've also placed a retroperitoneal drain in that collection. She stabilized and she was discharged a few days later. She was seen in clinic 1 month later, and she was actually doing really well. This is an ultrasound that was performed in our IR clinic. at the 1 month point, and you can see that there is like actually a superior pole and an inferior pole of the right kidney that looks somewhat normal with some small collection in between, but that has much improved compared to the prior ultrasound that I showed you. And so here I just wanted to touch on pediatric blunt renal trauma guidelines. These are the guidelines from 2019 based on the AST guidelines. And so the recommendations were basically that if the patient is hemodynamically stable, we should continue to manage these patients conservatively. However, if the patient has a severe trauma, meaning it's a grade 3 or above, or if the patient is unstable, the first line therapy should be basically angiography. And so now, basically people are moving away from surgeries, and so our role is bigger in managing this population. And I think that's a great thing because it helps prevent loss of organs. And that's it.
Nice, nicely done. Anyone has a question? We have time for just one question, I believe. A quick comment, just like I was a little concerned about the amount of radiation the kid had. Other than that, nicely done, really well done. So we'll move on to the next presenter. I'll invite Curtis Hornschedler to present his case. Curtis, you can take control.
Hey everybody, how are you guys doing? Great. Can you guys hear me okay?
Yeah, we can hear you.
Perfect.
Start screen sharing, please.
Let me share the screen. I know we're great. So my name is Curtis Hornschedler. I'm an R3 at Boston Medical Center. And like Raya, I'm also currently rotating at Boston Children's. And I had the pleasure of working with Dr. Bogart, Dr. Ahuja, who are, I believe, both on this call, and then also Dr. Tuning. So just had this really nice case, which I think illustrated a very challenging scenario. And we came up with a very innovative technique. And so I just wanted to share this case with you all. Okay, so the case involves a 19-year-old male with a history of ulcerative colitis and unfortunately a pretty complicated coagulopathic history. He has a complicated surgical history as well, which is significant for subtotal colectomy with end ileostomy as treatment for his UC at age 10. A few months subsequently, he underwent creation of an ileo-J pouch with an anal anastomosis and a diverting loop ileostomy. And then after that, he underwent takedown of his diverting loop ileostomy. He had been doing relatively well for the next couple of years, but in 2016, he began experiencing episodes of recurrent upper and lower GI bleeding. This was further complicated by portal vein thrombosis, and he actually underwent a TIPS at outside hospital, which was subsequently occluded. All of these records were at outside hospital and unfortunately were not really available to us, but it appears that several attempts at recanalization were unsuccessful. So in 2019, he was referred to Boston Children's for the surgical creation of a mesogonadal shunt, and he had some symptomatic improvement, but ultimately continued to have episodes of GI bleeding. Some relative history, of course, he's been on an extended course of Xarelto, and he's been on and off in the setting of multiple GI procedures, but he then presented on August 3rd with abdominal pain. I just want to play the CTs for you. So we have the axials on the screen left and coronals on the right. And so what we notice here first is that we have a TIPS, which is chronically occluded. There's some embolization coils in the right hepatic lobe, which unfortunately we don't really have much history on. And then here we can see the mesogonadal shunt as well as multiple mesenteric varices here. All right. And then further in the abdomen, we can see some other post-operative changes to the bowel. And then on the coronal images, we see similar findings here. Right? So coils, occluded tips, and the shunt. So this is just single axial and coronal images to demonstrate most pertinent findings. Here we see the anastomosis of the gonadal vein and to the mesenteric vein, and we see that there's an abrupt change in caliber here, very, very narrow. And then again, multiple varices that we see here. Same thing on the coronals, quite a bit of narrowing at the anastomosis, and again, the mesenteric varices. Was eventually discharged and came back in September for a planned procedure. First on the 29th, he underwent a pouchoscopy with GI, where biopsy samples were taken, and then he also underwent EGD, and he had multiple esophageal varices banded. The day after, he came to us where he underwent venography and venoplasty of the mesogonadal shunt. And at this time, we also measured some pressures. So from this case on the 30th, we see that we see this focal area of narrowing, which presumably corresponds to that anastomosis that I demonstrated on the CT. And then also importantly, we see here multiple collaterals here, lots of varices, which presumably are secondary to the delay in flow from this focal stenosis. A lot of numbers here, but basically the takeaway is that we measured pre and post gradients with improvement from 19 to 11 following angioplasty. Again, 11 is not a great number, but it certainly is an improvement. So then here are kind of just runs from the plasty. We see this waist here with subsequent breaking of the waist. And it seemed as though there were maybe two focal areas of stenosis. This would be corresponding to the anastomosis, and then a more vertical portion that we are guessing would correspond to possibly the confluence of the gonadal and the IVC. So he was, so here we have before and after digital subtraction, and we see a nice response here and also a resolution of these collaterals. So he was monitored for a few days and then discharged on the 1st of October. Unfortunately, he re-presented on the 3rd with a day of abdominal pain and nausea. The original plan was to have him monitored at home, but he had worsening of pain and actually had a low-grade temperature that night, prompting an emergency department visit. So in the ED, he had a CT performed, which unfortunately was poorly timed for evaluation of the mesogonadal shunt. They did end up getting another CTA 2 days later, and this is what we found. Essentially, again, that area of narrowing at the anastomosis, but now there's actually complete thrombosis of the shunt. And we can see that this tracks all the way to the confluence of the IVC, which is here. And then we also see this kind of stranding and thickening along the vessel wall. Right? And then we see this again on the coronal images. Now, I wish that I had saved the coronal where the confluence of the gonadal and the IVC is, but it really was a challenge to access this. I'll show you kind of what we saw on the initial runs. Before I do that, I guess he was started on a heparin drip until our procedure the following day. So we got right IJ access. We eventually put in a 8 French 35 super arrow sheath, parked it above the shunt. And then we did our initial runs and we see these collaterals here, but really no opacification of the shunt as expected. We tried for, at least a couple of hours with a variety of catheters, including C2s, C1s, SOS catheter, VERTs, Compi catheter, and really didn't have any success at accessing the shunt. So one of the fellows, Dr. Ahuja, had the brilliant idea of accessing the shunt directly percutaneously under ultrasound guidance. And so here with the yellow arrow, we see this hypoechoic kind of tubular structure corresponding to the thrombosed shunt. And then here we see the echo tip needle well within the shunt here. And then for orientation, we see the kind of rectus abdominis muscle here. And so what we ended up doing was getting access into the shunt percutaneously. We put a cope wire through this and then navigated the wire into the IVC. Once we were in the IVC, we were able to exchange that wire for a essentially a transcend wire. And then we came up from above and snared this wire. And then we flossed it through and through to the right IJ axis. So then here we can see two wires now. We switched out the transcend wire for a B18. And what we can see here is that the wire comes into the shunt, but actually out of the patient. So here is probably where we had accessed, and this portion of the wire is actually external to the patient. And we kept this wire here, given how difficult it was to get access as a safety wire. And then we placed a second wire, which we can see here. Initially is floating within the peritoneal cavity, but using a Compi catheter, we were actually able to direct it into the shunt. So then our initial runs, after accessing the shunt, we can see that there's non-opacification in the central portion of the shunt. And then again, we see multiple collaterals here. So our next step was to perform a suction thrombectomy. And we used the Indigo Penumbra Cat8 device with a lightning, which was very effective. I'll show you on the next slide kind of what we were able to get out. So quite a bit of clot. And then following the thrombectomy, we did a run, and here we see again, as we have been expecting, this focal area of narrowing at the anastomosis. There's a little bit of narrowing here as well. Part of that may be that our catheter and sheath are slightly occlusive. But what we went on to do here was serial angioplasties. So we did sequential 6mm and 8mm balloons. We see that there's a waist here, and then we see a nice break in the waist. Following angioplasty, we topped it off with just a nice, almost like a Fogarty balloon. We kind of just did a balloon sweep through the shunt. Okay, so then this was our final run. And I'll point out a few things here. It's not the greatest run. There's still a few areas of filling defects, which may just be kind of chronic clot. But what we do notice is, again, there is a more abrupt filling of the IVC and also decrease in the amount of collateralization here. So that is the end of the case. A few things that I do want to highlight. This is a complicated case, not in just the anatomy, but also the patient's underlying issue, which is his coagulopathy. It seems that this has happened to him several times in terms of clotting, where he's on an anticoagulation therapy. He comes off of it because he has GI bleeding and he has to undergo a procedure. And it's just kind of like a vicious cycle, really. With respect to his shunt itself, kind of the things that we were thinking about is that area of narrowing at the anastomosis. It really is something that either needs to be revised, or we had talked a lot about possibly placing a shunt or a stent rather. But the problem with the stent was that we really hesitated to committing the patient to metal. Ideally, we'd like to salvage this without having to go back into the abdomen and losing this potential graft that was created from surgery. So just wanted to share a very challenging case, but also a really great idea that one of our fellows had. And I think that it bought us some time for this patient who is still actively undergoing treatment and care.
Yeah, very difficult. Thank you for showing a very difficult case, because it's hard to manage such situation because stent has a lifetime of his own. if you place a stent, how long will it last? Because we already have a chronically occluded tips, and surgery will be difficult, but probably that's the right answer. Anybody else has a question? Okay, so with this, I'll seek Kosti's attention. He has to do the challenging job of selecting. I know they're all winners, but we have to do the honors, Kosti.
Well, I thought they were all spectacular, actually. I'm very, very impressed with the level of presentations here. It's very hard to choose here. I have to say, though, that I will choose the last case because the idea, not just the presentation, the combination of the difficulty there was very, very extreme. And I like the fact that the idea of the solution came from another fellow and not an attending. So you should share the award with the one who had the idea, for sure. So that's my vote. I don't know. I wish I could give them all a prize, but I think the last one stood up a little more in my mind.
Perfect. Thanks, Kurt. Thanks, Kosti. Appreciate it. And for everyone, before we part ways, like next month again, we'll have this the session on 15th, and Dr. Alda Tam from Houston, MD Anderson, will be speaking on the future, which will be the second part of the series. And also, don't forget to go to EDS and send your code for the day to get your CME for the day. And thanks everyone. Thanks Kosti for showing up and doing a great presentation.
Great.
Thanks everyone. See you guys later. Bye-bye. Bye everyone.